Thank you. Hello again, everybody. First, I would like to ask you, how many of you are using ultrasound? Oh, sorry. After lunch. How many of you are using ultrasound in your clinics? Yeah, I would recommend you to start using ultrasound. It's not that difficult to learn on superficial tendons like Achilles and patella. And there are courses, I don't know about Greece, but in Spain and other countries, England, because you will love it. I mean, you have the patient and you clinically examine the patient and you think about the diagnosis. And if you then have ultrasound equipment, you can immediately put the probe on and either verify the diagnosis or exclude the diagnosis. And you can show the patient, you show him, this is how it looks, and now you have to be careful, you should do that and that and that. So for me, it has been a highlight to get involved in ultrasound, and I think you will like it. So that's a recommendation. Well, now we are going to talk about treatments. So based on my previous talk today, as I told you, we started first the conservative treatments with eccentric training, painful exercises as we discussed, so I will quickly jump forward. We did multiple studies on that. First a pilot study, and then we did an RCT comparing painful concentric training, only heel raises, compared with eccentric, and there was a massive difference. We actually had to stop the study after including half the numbers of patients because there was basically no one in the concentric group that could continue. The pain got worse and worse and worse, and they couldn't do the exercise. And we cannot explain that, but there is maybe one explanation, and that is that eccentric loading requires less oxygen. It's less oxygen demanding compared to concentric. So that could be a factor. Then we did larger studies, over 100 patients, and we did ultrasound follow-ups and Doppler follow-ups, and the conclusion was that it was a good method, and the results were reproduced in other countries also, other groups. So then there are also other types of loading regimens over the years that have come out, but the good thing is that we don't need to be scared of pain when we deal with chronic painful Achilles tendinopathy in the mid portion. I also told you about the background to why we used the sclerosing injections, nerves on this side, passing together with the blood vessels we could find with the Doppler, It's important to know that you have to provoke the patient before you start this treatment. So if they come first patient in the morning, the blood flow might not be very massive, maybe only a minor region here, but if you provoke them with some jogging or exercise before the treatment, you might have vessels coming all the way around here. So standardized to provoke them if you decide to use sclerosing injections. We don't use it very much, actually, and that is because we have moved over to other methods. But what we did was that we learned a lot about the location for pain. I think I was involved at least in 2, 3, maybe 4,000 injections, and that's actually how I learned the ultrasound, because I was the radiologist's third hand. He did all the difficult stuff he did, put the needle in, probe, and the only thing I did was to push in the polydoconal when he told me to push. But I sat there and he told me everything he knew about ultrasound techniques and examination, so that's how I learned to use ultrasound. So the negative side is that it's quite difficult if you want to do it the proper way. And quite often multiple treatments are needed. And we used 8 weeks in between the injections. So it might take, for the mid portion on average, I think it was 3 injections. So that's quite a long period before the result is good. So we have moved away from that method for the mid portion, and instead we have moved into surgical treatment. So we started to move away from surgery, and then we now have moved back to surgery. And that is because we know much more about the mid portion today. But it's very important that you have a correct diagnosis. So I emphasize that again. Use ultrasound to get the correct diagnosis. If you use MRI, you will not get any information about the blood flow. So we prefer ultrasound, and it's also a dynamic examination. You can move the probe. It's not a static picture. So you can move the probe and you can look in different angles. You can find the plantaris. So, you know, I used to operate these tendons with open surgery inside the Achilles. And that is even today, it's the most commonly used method. When you end up having taken the decision to operate, it's quite often open surgery. And what we did was that we opened up the tendon and we cut out everything that we believed looked pathological. So it was not very specific. And sometimes you ended up taking away maybe 80% of the tendon thickness. You suture the remnants, you put them in a cast, slow rehab, and around 4 to 6 months of rehabilitation. And for the high-level athletes, very few came back to the same level they had before they were injured. So now we have moved away from that method because now we know much more. We know that, oops, this is tricky, have to be clever to use this one. We know now that the nerves are outside here, you know, so there's no need to go inside. So now instead we use a mini-invasive surgical procedure. We provoke the patient first, standardize this provocation, you know, and then we scan them and we find the blood flow here. We put local anesthesia in on the deep side of the tendon here, sometimes enough with a couple of milliliters Xylocam plus adrenaline. This is a very old histological picture showing that the fat tissue on the deep side has started to grow into the tendon, and that is a very common finding. When you do your small incision here on your deep side and go in, the intention is now to go in and scrape loose the fat tissue. So scrape loose this white tissue on the deep side of the tendon. All the way into tendon. You don't go inside the tendon, but you scrape loose the fat tissue. And quite often this fat tissue has started to move into the tendon. So it's quite difficult to scrape it away sometimes. And that's why I think maybe hydrodissection sometimes is not enough, because you cannot release the layers there. And you can stick with the very small incision. Sometimes only 1 centimeter incision is needed, and then you can slide proximal and distal, make sure that you scrape all the way over on the other side. That simple procedure, you know, because you have not been inside the Achilles, you don't need to be worried about loading. So they rest the first day to minimize the bleeding. Then they start immediately full weight-bearing loading, some biking, and increase the load week by week. And the majority are back in full sports after 5 to 6 weeks. We had an Arsenal player who was back playing in the Premier League after 4 weeks. So for athletes, it's a really good procedure, you know, short time away from the pitch. You have to be careful with the wound, because even if it's a small wound, that can rupture. There is quite a lot of pressure under the skin, so leave the sutures in for 3 weeks. We discussed with plastic surgeons, because we had a couple of cases with wound ruptures. When they started to run and play, and suddenly the wound gapped up, and that was the high pressure in there causing that. So leave the sutures for 3 weeks to be on the safe side. Looking at the tendon structure after that procedure, we see that similar like that we saw from eccentrics, that the tendon remodel. but very much quicker. So this is already 4 months after surgery. This tendon was operated, and 4 months later the tendon looks like this. The only remnant of surgery is scar tissue here. You see this little dark line here. So there's a quick remodeling of the tendon when you interfere on the deep side. But not all patients get well after that procedure. When we started this, we positioned ourselves on the lateral side of the patient. The patient was laying prone, like this. So we did a scraping procedure from the lateral side. And then we had patients coming back complaining about medial side pain. And we didn't really know what to do with those patients until we had this track and field athletes from London I showed you. Then we realized that, the plantaris tendon might be involved. So then we changed the approach to instead do these operations from the medial side. And if the plantaris was involved, we very carefully removed the plantaris. So this is a couple of ultrasound pictures showing the Achilles, tendinopathic Achilles. Here you have the plantaris located very close to the tendon. If you like, you can provoke the patient when you have this picture, and then you can see how the plantaris will slide up and down along the medial side. This is another type of plantaris, much wider. And here you can trace blood flow in between the Achilles and the plantaris. So there are many different positions, but if you decide to do this operation, do it from the medial side. And if you're not really sure what level to put the incision, try to put it in the region where you have most high blood flow, and that quite often matches where you have most tenderness. So when you palpate, you can put a marker. This is where there is most tenderness, and if that matches the high blood flow, then that's the best position for your incision. Okay. So we combine sometimes and quite often the procedure. We do the scraping and removal of the plantaris. Exactly same. Sometimes you need to lengthen the incision a little bit because you want to remove the plantaris in the whole region where it touches the Achilles, and sometimes that is a little higher and a little lower. So then you need to lengthen the incision a little bit. Complications, we've had a few complications, most often in patients that have had previous cortisone injections. So we are careful with that now. If they've had previous cortisone injections, we give them prophylactic antibiotics after surgery. The tissue is more sensitive after injection therapy. And many studies have been done using this methodology. We started already 2007, and then we had large numbers, and interestingly, we had the best results in the high-level athletes. We differentiated them into groups: high-level athletes, professionals, recreational athletes, and non-actives. And I think the non-actives, overweight non-active individuals, around 70-75% good results, and high-level athletes was 95% good results. So I don't know, but we have a feeling that the athletes, they started very quickly to move, while the non-active individuals, they were a little worried to move, and that was not really their personality to move, so they took it a little bit easier. So maybe movement early after this operation is needed. Other groups, Australian group, Bedi group, have had the same good results. So that is a method that I really want you to start to use, because you will find it good. I promise you. Then there are the cases that have a normal Achilles but still complain of sharp Achilles tendon pain. We discussed this earlier today. Then you should think about them having only a plantaris related pain. So don't give up if you only find this normal Achilles. have a cross view when you examine them with ultrasound, and then you probably will find a close by located plantaris tendon, and same procedure in local anesthesia, just take it out. It's less common, of course, but there are cases we have published a material with that. So for patients that come to you with mid-portion Achilles tendinopathy, you can be very confident that you will cure that patient. Very, very confident. I think at least 95% chance that you will cure that patient. Start with correct diagnosis, then you start with the conservative management, see how they respond to eccentrics. If you have a poor result, then you need more invasive treatments. Use this simple scraping surgical treatment and think about the plantaris on the medial side. And I promise you, you will be happy with the results. So now it will be more difficult, because now we moved on to the insertion. And as you know from the literature, there is not a lot of science dealing with surgery and also conservative treatment for the insertion. Multiple approaches has been described, open procedures, like this one here, where you split the Achilles to reach the bone in under, quite major surgery. And there are other procedures where you divide the tendon insertion like this, take away pathology and resuture and re-anchor the tendon. And there are arthroscopical approaches. Many of them are associated with very, very long rehab processes. If you detach the tendon, it's up to 1 year rehab. The clinical results are varying. Again, we discussed today the research findings that surprised us a lot, because if you study the literature, this subcutaneous bursa is never mentioned. If you study a description of a surgical method, what they say sometimes is that they slide it through the subcutaneous bursa to reach the tendon. There is never anything about removing the bursa or anything like that. So I think it has been a forgotten tissue in the insertion. Have a little bit better ideas about the diagnosis, we use quite a lot of diagnostic injections. So with ultrasound guidance, you can, if they have symptoms from the whole heel, you can say you don't know where to start. With ultrasound guidance, you can start to put local anesthesia in the subcutaneous bursa alone, and then have them to exercise a little bit. If they then are completely pain-free, then it's possible that you don't need to bother about all the other pathology. I will show you a case that were like that a little later. So use diagnostic injections. That's very useful. So when you scan them with the ultrasound, if there is an activity in the reticulateral bursa, they quite often have a high blood flow in the bursa walls. There is also other types of pathology here, but maybe this is the most important. Here you have a high blood flow, especially in the subcutaneous bursa. There is also Haglund deformity and changes in this bursa, but you have quite a lot of blood flow here. So you get lots of ideas about what you need to take care of when you do the ultrasound and Doppler scanning. So we have started to use that, and I will now show you how we operate cases that have pathology in both bursa, Haglund deformity, and also the distal tendon. So we do those procedures in local anesthesia. It works very well. You can cut out big pieces from the heel bone in local anesthesia. So maybe altogether 6, 7, 8 milliliters of xylocaine with adrenaline, starting here in this case on the lateral border, sliding down here, then you go inside the bursa and fill up the whole subcutaneous bursa with local, and then you go into the angle between the bone and tendon and put it in the retrocalcaneal bursa and also on the deep side of the distal tendon and in towards the periosteum. So 6-7 milliliters is enough. So I will show you a couple of slides from the operation. So here we have done the lateral incision. So we always put the incision on either the lateral side or the medial side. Medial if there is a suspicion of plantaris involvement. So not straight back, because if they have problems with the scar, there will be problems in the shoes. So we put it on the sides. So from that lateral incision, you can slide in and remove the whole subcutaneous bursa. So first we detach it carefully from the skin side, and then from the deep side, and then you slide all the way over to the medial side and take out the whole bursa in one piece. And it's important to make sure that you scrape away the deep wall, because that's where there were most nerves when we did those studies on nerve supply. So the whole bursa shall be taken out, but make sure that make sure that you scrape the deep side here. The next step is to remove the Haglund deformity, and you don't need to perform a hole in the tendon. You can lift up the tendon. If you put the foot in plantar flexion, it's very easy to lift up the tendon, and then you go in here with your chisel, like I did here, and with this one you hammer off the upper part of the heel bone all the way over to the medial side. And it works fine in local anesthesia. You don't need to worry about that. And here I've also taken away the retrocalcaneal bursa and scraped the deep side of the tendon. So they end up having this defect here, and they have a defect here where the subcutaneous bursa was taken out. Here we need a longer rehab, and that's mainly because you need to have these defects to fill with proper tissue. Initially we started to push them very early, but we regretted that because the filling of the defect was not good enough, and that lengthened the rehab dramatically. So it takes about 6 weeks to fill this defect here in front of the heel bone, and when they come for the 6-week follow-up, it should look like this. Here you have the heel bone, the tendon, and this defect was here, has now filled with tissue that is pretty good. There is no fluid accumulation, and it looks a little bit similar like tendon tissue. So this is good enough to start to load on. So that's the key for the rehab. So you see here we are quite careful the first 6 weeks. And then they gradually increase the loading and they start running, but seldom before 3 months. And the high-level runners, they are back running, but it takes a little time before they can run in good speed. So if it's a high-level runner, you can tell them that you have to wait at least 4 months before you can expect to run in a decent speed. Again, sutures stay in for 3 weeks. Not very many publications. We did one 2014, the first one, and now there is a group that I have a little bit been involved with, a group at a traditional hospital in southern Sweden. I have only instructed them how to diagnose and do the operation, and then they have done everything themselves, and they are really satisfied with the results. Interestingly, this foot and ankle surgeon, he used to use the Nunley procedure, where you divide the tendon from its insertion on the severe cases. And in this material, 10 out of the 23 cases, he would have done that traumatic procedure. But 9 of those cases were good with this more simple procedure. So it works also in the quite difficult cases. Also here, the plantaris tendon can be involved, and it can also be involved alone. So the patient can come in and only have pain on the medial side of the insertion, and you don't find very much maybe when you scan them. Maybe there is some thickening on the medial side of the insertion and some tendinopathy, but it's quite often minor findings. You see here the ultrasound view, you can maybe think that there is a little thickening here on the medial side, and down here maybe a little sharpening in the bone. That is the plantaris insertion. That sometimes is a little like a spur-like insertion. So then it might be that the only thing you need to do is to go in and find the plantaris a little bit higher up, follow it down like here, and take it out. So you see it's massive plantaris here. Normal size of the plantaris is like a guitar string, so it can be enlarged. Okay, so remember that this subcutaneous bursa, I cannot tell you enough. So this could be the only thing that needs to be taken away. We have published that in a case study. And you see here cases like this with lots of bone, loose bone, big mountain of bone back here. It was not causing the pain. The pain was caused by the bursa. And I will end by showing this really fantastic story. This lady, her name is Lisa Bentley. She was one of the best Ironman female athletes in the world, despite that she also suffered from cystic fibrosis. I didn't think that was possible, but that's the way it was. She was diagnosed with cystic fibrosis when she was 18. And she continued to run, despite that all doctors said, oh, no, you cannot run with this disease, you have to be careful, But she found out that the more she exercised, the better shape her lungs were in. So she came to Umeå 2010, something like that. And she had been having problems with the insertion. She couldn't use shoes, she couldn't touch the skin at the back of the heels. She couldn't bike in her traditional bike shoes because of compression pain. So she was walking in flip-flops when she came to Umeå, and that was wintertime, so you can imagine. When we examined her, she had a normal resting tonus, and everything was basically normal with the exception of her very, very, very tender posterior heel. So you could basically not touch this part back here. And she had been, she had seen many orthopedic surgeons in America, and they had tried all kinds of treatments, loading treatments, insoles, shoe changes, Tromil injections, PRP injections. Nothing worked. And when she was scanned, ultrasound scan, you see here, this here is the thickness of the subcutaneous bursa, but in under you have these massive bone formations. This is probably loose, this might be anchored. Looking in the transverse view, you have like a mountain here now, but you also have this thick bursa. And here we measure the size of the bursa. Higher up, her Achilles was quite normal, some tendinopathy, but that's normal for runners to have. They don't need to have pain from that. She had a little Haglund deformity and some chronic changes in the retrocranial bursa, but she was not tender in this region. So the orthopedic surgeon decision in America was the only thing we can do is to detach your tendon, and you need to face a 9 to 12 month rehab period. But the problem with her was that if she didn't exercise, daily exercise, her lungs became worse. So she didn't dare to have a massive operation to not be able to do any exercise. So that's why she came for a second opinion, and I didn't know what to do with her, but we had these research findings out when we knew more about the innovation, so we said, okay, we can try to put local in only the subcutaneous bursa. And not touching anything else, and see how you respond to that. So this is how we did. We put the needle in here, filled up the whole bursa with local, put shoes on with heel pad on, and had her to jog 10 minutes jogging, and she came back smiling and said, "I'm pain-free." So then we said, okay, then we can offer to only take away the bursa, and that procedure you can still continue to exercise. The first day you need to be a little careful so it doesn't bleed too much, but then you can go back exercise, not running, but you can be in the pool and do other activities. Small incision on the lateral side, bursa out. This rehab, early activity, biking early, light jogging. She could start already after 6 weeks. She was running without pain after 8 weeks, and she did 10 kilometers on 38 minutes after 6 months. And she still has this amazing bone pathology in the insertion, but it was not causing pain. So that is my message to you. Don't look too much at the x-rays. Try diagnostics injections, and maybe you end up by not needing to remove all the bone, because it's a dramatic difference to think. You can think if you were in rehab for 12 months, it's a tough rehab. Okay, thank you very much. Soon time for a beer.
Ερωτήσεις για την χειρουργική αντιμετώπιση. So, let me start with 2 questions. How easy is how visible are the fat infiltration in the mid portion of Achilles? So, can you see it easily and be sure that you removed all the fat infiltration? Is it easy to see? One, and the second one is there regarding the insertion, is there a need to have 2 separate incisions for some patients, medial and lateral, for I don't know for what pathology? So these 2.
Yeah, first question. It's easy to feel that you have got rid of the fat, because you use the scalpel, and when there is a certain feeling when you have reached the tendon, and also you see it when you have where you have your incision, you see it. So then when you have removed everything in where you have your incision, then you just go distal and proximal and scrape with the blade. And you can scrape quite hard. There is no risk that you will cut the tendon, and you can scrape quite hard. Then it bleeds, of course, so you coagulate as much as you can of the bleeders. So that will be easy for you to know. And then there is sometimes a need for 2 incisions in the insertion, because if they have lots of changes on the lateral side, sometimes there is also sharp bone on the lateral side of the calcaneus, then you need to have 1 incision there to remove that, and then you cannot reach the plantaris on the other side. So sometimes you need 1 for the medial and 1 for the lateral. But we have never seen any complications considering necrosis, skin necrosis and things like that. Of course, you should be very careful with patients that have been operated in the insertion before, because then the blood flow has been disturbed, and if you do incisions very close to each other, there might be skin necrosis. But you can always discuss with the plastic surgeon what they think, what is the best position. He has been operated before, what do you suggest? And the good thing with ultrasound is that you can minimize the length of the incision. So if you want to take out a sharp edge somewhere, you can minimize it.
Κάποια ερώτηση? So, you think there's no place anymore to do this big operation like Nanley, so remove all the tendon, or you still have some patients that you have to refer them for big old type operations in the insertion? Yeah. Are there cases like that anymore?
Oh yes, I think there are cases where you need to detach, but I don't think we need to detach as many as we believed before. Here in he's a famous ankle surgeon in South Sweden, and for him it was 9 out of 10. So but there will always be cases where you need to do it.
which cases are that big bones?
Yeah, if they have, if the whole, if there is a transverse big piece of bone sticking out, you know, and we have discussed whether you could do it in two sequences. So you do one half, and then you wait 6 weeks, and then you do the other half. So to stay away from the full division. Because the negative side when you divide the Achilles is that you also lose some of the tension in the Achilles. So even if you reinsert it, you have changed the tonus in the tendon, so you might be less good in doing quick and strong plantar flexion activities.
So when you think that this big bone is the origin of the pain, and this big bone cannot be taken out with smaller incisions.
Yeah, okay. but maybe you can do it in 2 sessions. But we have not done that yet, but we are discussing it. For high-level athletes, you know, the tendon detachment, they never improve on their previous records after a detachment.
Excuse me, what is your opinion about if this can happen by arthroscopic means? This operation of ulcer removal or plantar tendon split up?
Yeah, you can do the Haglund and the retrocalcaneal bursa. That can be done, but you cannot do the subcutaneous bursa. It's too dangerous. You will go through the skin. You will destroy the skin. Because we have tried, but you should not do that, because if you destroy the superficial side too much, you end up having skin necrosis and big problems. So I cannot recommend that. And then other prominences, you know, plantaris will be very difficult to remove down in its insertion, because it's very tight. To find that with the scope, it will be tight. But if it's only Haglund and retrocalcaneal bursa, of course you can do that.
If you have a bone spare, central bone spare, that you think you have to remove the tip of the bone, you will go for a midline incision, or you totally avoid the midline incision, even though the spur is there in the middle?
Yeah. If there is a loose bone spur in the middle of the insertion, and the diagnostic tests have shown that this is where the pain is coming from, then we do a longitudinal incision in the tendon, a minor longitudinal incision over the bone spur. So we use the ultrasound to identify, and then we use as small as possible to go down. So again, the ultrasound helps us to minimize everything. You know, the trauma is minimized.
Okay. Κάποια ερώτηση? Κρατήστε το μήνυμα. Ναι.
So if you diagnose that it's a bursa by injection, surgery is number one choice of treatment right away.
Yeah. We have tried before sclerosing injections to try to have it to fibrose, but it's difficult because it's large. But if it's only a minor part of the bursa that's thick and only a minor part that's causing pain, then you can try local polydocanol. We have done that, and that sometimes works fine. But if it's the whole bursa, and you know, the typical patients, they cannot wear shoes, they cannot lay on their back because they have burning pain at the heel, you know, and the heel is very prominent. And those ones, it's better to take it out, the whole one. And it's a minor procedure. But tell them to be careful afterwards, because they lose sensation at the back of the heel. So they get numbed at the back of the heel. And initially I thought, this is going to be problematic because no one wants to be numbed at the back of the heel. But no patient this far has complained about that, because they are so happy that the burning pain is gone. But if they are not careful, you know, if they use a shoe the week after, they can dig a hole in the skin. So they have to be wearing a shoe with open heel for 6 weeks after surgery. They have a protection feeling, so if they get a hit, they feel it, but the superficial sensitivity is gone.
Τώρα είναι η ευκαιρία σας. Έχετε κάποια άλλη απορία? Ένα μήνυμα που πρέπει να πάρετε ίσως οι ορθοπαιδικοί είναι ότι βοηθούν πάρα πολύ οι εγχύσεις ξυλοκαΐνης σε περιοχές που υποψιάζει για να βοηθηθεί στη διάγνωσή σου. Αυτό το κάνουμε συχνά και είναι και μια δική μου πρόταση. Αν έχετε απορίες, κάντε μια έγχυση ξυλοκαΐνης εκεί που νομίζω ότι είναι αιτή. Αν ο πόνος εξαφανιστεί, ξέρετε τον ένοχο και ξέρετε τι να πάτε να πειράξετε.
Αυτό έχει πολύ μεγάλη σημασία. Πολλές φορές βλέπω μια μαγνητική τομογραφία και περιγράφονται ένα σωρό παθολογίες. Μερική ρήξη, ασβεστώσεις, μπουρσίτιδες. Και λέει τώρα, είναι όλα ή είναι κάτι από αυτά. Και συνήθως δεν είναι όλα που προκαλούν τον πόνο. Οπότε ένας καλός τρόπος για να τα απομονώσουμε τι είναι, πάμε λοιπόν αναπεριοχή που θεωρούμε ότι πάσχει και την απομονώνουμε. Πώς? Κάνουμε μια ένεση με ξυλοκαΐνη και τοπικά. Είναι λοιπόν η μπούρσα που πιθανώς πάσχει στον αχύλιο. Κάνουμε την ένεση, και αν την κάνουμε με την καθοδήγηση του περίπου, ξέρουμε ότι είμαστε μέσα στην μπούρσα και δεν πήγαμε παρά έξω. Αν δεν πονά ο πάσχων, πολλές φορές το κάνουμε λοιπόν και του λέμε βγες έξω στο σαλόνι, κάθισε λίγο, κάνε μια βόλτα, πάρε έναν καφέ και έλα σε 1/4 και πες μας πώς είσαι. Αν αυτό το πράγμα του μειώσει ή του εξαλείψει τον πόνο, ανακαλύψαμε τι πάσχει από όλα αυτά που περιγράφονται στη μαγνητική τομογραφία. Δεν είναι αυτό. Πάμε παρακάτω. Και έτσι με αυτόν τον τρόπο μπορούμε τελικά να αντιμετωπίσουμε την αιτία του πόνου. Γιατί ο ασθενής κατά βάση σε εμάς έρχεται και τον πόνο. Στη χρόνια τενοντοπάθεια. Αν δεν πονούσε, μάλλον δεν θα έρχονταν ποτέ.
Ευχαριστούμε πάρα πολύ όλους. Thank you very much. Yes.
One last comment. Learn how to use ultrasound. You will love it. Okay, thank you.